All right, what is the definition of pain? What is the definition of pain?
Whatever the patient says.
You got it. You got it. We are not the pain police, so it's whatever the patient says it is. What is, why do we not give IM pain meds to burden patients? Did we talk about that?
It can get to the muscle, the burn can get to the muscle, so it can mess with absorption.
Mess with absorption. Yes, that's the most simplest. We don't know how, when the patient, the patient's going to have fluid and electrolyte imbalance, and we don't know when that fluid shift is going to occur. And if it occurs at the wrong time, A, they may not get the medicine, or B, they may get flooded with too much medicine. So it's really bad for absorption. So best route is IV pain medications. Okay. All right. Focusing on respiratory. Let's talk about COPD. What happens if you give a COPD patient too much oxygen? What will happen to their breathing?
Like, be depressed, because then the body thinks that they don't need to work anymore, basically.
You got it. You got it. It causes a hypoxic drive. Thus, well, hypoxia is what drives them to breathe. It causes apnea and low respiratory rates. They will stop breathing if you give them too much oxygen. Very good. Very good. Hypoventilation was the word that I was looking for. Hypoventilation and apnea is what will occur if you give somebody with COPD too much. What is a teaching point? You walk in and you've got a COPD patient with lots of thick secretions. What's something that you can do as the nurse to help with those thick secretions?
Suctioning?
Suctioning, but what can we have the patient do to help thin those secretions out?
Oh, increase fluids.
Mm-hmm. You got it. You got it. Increase that fluid intake unless it's contraindicated. But again, don't read into the question, right? We're not telling you that it's a COPD or with CHF. We're saying this patient has COPD, that's it. So increase fluid intake to thin those respiratory secretions. Absolutely. You walk in and your COPDers in a little bit of respiratory distress. They're satting 86 and they're slumped down in the bed like this. What are you going to do? Sit them up. That's right. It's not Grey's Anatomy. Sit them up. We're not intubating. Get them up 90 degrees, arms on the bedside table. That's the first thing you want to do with our COPDs. Sit them up. Make sure they're drinking lots of fluid to thin those secretions. Absolutely. And don't give them too much oxygen. All right. We've got somebody with COPD. When should we encourage them to eat? Before exercise or after exercise?
Before,
because they're going to be tired after that PT exercise around the hospital. They're not going to want to eat. What kind of diet should we put on COPDers?
just high calorie, high protein.
You got it. High calorie protein, because they are working so hard to breathe. They're burning so many calories just to breathe. So we need lots of calories. I remember my mom, she loved milkshakes. I'd give her milkshakes every time I saw her because A, she'd eat it. B, she needed the calories. So whatever we can get them to get those calories in and eat. Good, good, good. All right. Tell me about pneumonia. How does a patient present if they've got pneumonia?
Crackles in the lungs, green sputum, stridor.
Stridor. Yeah, they look sick. Fever, sputum, hoarse breath sounds, crackles in the breath sounds. Absolutely, they look sick. What is the thing that we need to get before we start them on antibiotics?
Culture.
Cultures. Always remember to get your cultures, blood cultures, urine cultures, all the cultures before you start them on antibiotics, because we got to figure out what's going on with this patient. All right. Very good. And when we talk about pneumonia, or let's switch gears a little bit. I'm looking to see where my pneumonia, yeah. And right-sided, left-sided heart failure. How does the patient present with left-sided heart failure? Think lungs.
Yeah, I go to the lungs, so like, isn't that when you'll hear like the crackles and stuff?
Yes, absolutely. And us talking about crackles with our pneumonia patient kind of triggered me to think about left-sided heart failure. Remember, the fluid is backing up to the lungs. So crackles, pink frothy sputum. Right-sided heart failure, it's backing up to the body. So that's where we're going to see that JVD, peripheral edema, ascites. Okay, good, good, good. So remember, left-sided heart failure, you kind of have that lung complication going on there. All right, so we're getting our cultures first before we start our pneumonia patients on antibiotics. Before COVID, what was the number one cause of death for our elderly population? Was it flu or pneumonia? You got it, Ivory. Pneumonia. I saw you mouth pneumonia. It is. So we take it very, very seriously when we have a patient present like with signs and symptoms. Get a chest X-ray, probably see the consolidation, and then you know you've got a situation on your hands. Excellent. All right. Those secretions. We have somebody come in with a tension pneumothorax in the right lung. Which way is the trachea going to deviate? Towards the right or towards the left? Left. Love it. Left. It's gonna deviate to the good side, right? Your body is so smart. It knows I'm losing oxygen on the left side. I'm not getting any breaths in. I'm gonna deviate to the left and see if I can get some more oxygen over here. Isn't that crazy? If you really think about it, that's crazy. What's our treatment for a pneumothorax? I know I said tension pneumothorax, but what's our treatment for a pneumothorax? What procedure?
Tube?
Yes. Good. Dang, you're on it today. Yes, thoracentesis. Everybody got that? So you stick a needle in, you pull it out. Sometimes you see it with, a hemothorax or one that has infection in it, blah, blah, blah. You use my mother-in-law had pneumonia with lots of fluid and yucky stuff built up in her lungs, and they did a thoracentesis. What is a risk factor of doing a thoracentesis? So let's say you're doing a thoracentesis for pneumonia. What can you then cause in the lungs?
Pneumothorax.
You got it. That's that weird catch-22. Sometimes you do a thoracentesis to treat a pneumothorax, or sometimes you cause a pneumothorax from doing a thoracentesis. So remember, those two kind of play hand in hand together. Great work. Great work. All right, strep throat. We got somebody with pharyngitis, strep throat, the white patches in the throat, all that fun, yucky stuff. What is our treatment? It's our basic treatment for strep throat.
Antibiotics?
For how long?
It's like 10 days, right?
Yeah, 10 days. You got it. And so we want to educate, finish the whole course, right? And you will find that nurses end up being the worst patients with that kind of jazz. We never finish our full course of antibiotics. Finish that full course of antibiotics. Good, good, good. All right. What does a spacer do for us?
Enables the medication to actually go to lungs instead of go to the mouth.
Absolutely. Gets that medication deeper into the lungs. Very good. All right. Switching gears a little bit, talking about OR. What is the number one complication of general anesthesia that can develop in the lungs?
Is it atelectasis?
Yes, very good. Y'all, both of you agree with that? Whole team agrees with atelectasis? Absolutely. So what is happening? Right, our alveoli are getting collapsed because we gave them the anesthesia. Patient's not breathing as deep. Maybe they've been supine for a really long time. So atelectasis is a really common complication of general anesthesia. How do we open them back up? What's something we have at the bedside?
Bedside?
Yeah, it's at the bedside. We're like, hey, please do this, 10 times an hour.
IS.
Yeah, instead of spirometer. Very good. That helps pop it back open, right? So very, very good. All right. Okay. When we're talking about OR, a lot of people we need to look out for, but who's most at risk for having complications for surgery in general? Population.
The elderly.
Elderly with comorbidities, right? That is who's going to be our big risk factor. So take a look at the history of any patient. Are any of you interested in going to OR nursing? It never really, oh my God. It never really scared me for a second. I was like, she's getting attacked. It never really interested me because I can't stand for like hours at a time. I think I would just die. And I'd be that person that broke sterile, field all the time. That being said, if you get a question, if you start thinking about your patient population, look at who has comorbidities like diabetes, right? Because what happens with our diabetic patients?
They're slower to heal because
You got
of
it.
the circulation problem.
Or circulation, slower to heal, risk for infection. Absolutely. So if you have a test question that's like, hey, who are you going to be assessing more frequently? Who are you more worried about? Look for those elderly patients with comorbidities. All right. Very good, guys. Very good. Tell me what an unlicensed assistive personnel can help you with, both in OR and on the medical unit. Or surgical unit, medical unit. What can an unlicensed assistive personnel help you with?
They can help with ADLs, sometimes depending on the hospital, vital signs, basic care for the patient. But
And when you say basic care, what does that mean?
So like helping them get up, get food, order food, use the restroom, do bathing, yeah.
Got it. Okay. And then they can get you supplies, can't they?
Mm-hmm.
They can get you some supplies. They can get the, patient drinks, that kind of stuff. What can they not do?
Medication.
Medication?
Assess.
Assess? There's one last one.
Skills.
Educate.
Educate. There you go. They can't eat. Educate, assess, or teach. And I know educate and teach are the same word, but used in different ways. I always remember they can't eat. Educate, assess, or teach. That's big. So remember, like, they can reinforce teaching, like, oh, you've talked to them about incision care. They can go get you the patient a pamphlet, but they can't teach about incision care. That's your job. Okay. And they can't assess a patient. They can say, hey, I don't like the vital signs in room. All right, took the vital signs. Here they are. And, from Ms. Smith, I think this is what's going on. That's obviously, you'd never be disrespectful and say, you're not allowed to tell me what's going on. You say, okay, thank you so much. But you're going to go in and assess your patient. You'd never be hurtful or disrespectful, but you'd go in and assess your patient yourself. Excellent. Okay. All right. When do we provide our education for our patients that are having surgery? When is the best time to educate on postoperative care and all that stuff? Admission and before the procedure, when they don't have anything on board, right? Have any of you ever had surgery? No. I have a few times. And afterwards, they'll tell you all this stuff. And I don't remember any of it because I don't know about y'all, but I don't take narcotics. So when you get narcotics, I'm like in the spirit world. I don't know what's happening. And I remember I went for a follow-up and they're like, but I told you that. I'm like, yeah, I was also on morphine. So what do you want from me? So always educate before the procedure when they don't have anything on board. Absolutely. Good. And well, I don't want to confuse you, so I'll pick that up. Okay, good. All right. What does phlebitis look like?
Red, warm, and painful around the insertion site of the IV.
Yep, around that vein. Very good. What does infiltration look like?
Kind of like edema near the insertion site. Imagine if there's like a bunch of saline or something that got dispersed throughout the skin.
You got it. Absolutely. And then, what's the difference between extravasation and infiltration? What's extravasation?
It's like when certain fluids get into I forget which ones. I know we talked about this. Something about like a different Like potassium? Oh, I forget.
Yeah. The bad ones like chemotherapy, potassium, the very caustic medications. Even some hypertonic IV solutions can be considered like vesicants. And then if they, if it infiltrates or breaks through the vein, or something happens, the catheter gets dislodged, it causes an extravasation where the skin and the area around it would start to slough, and it's a bad day for everybody. So the big difference between that versus infiltration is infiltration is just fluid, in the tissue. It hurts, but we can do some warm compresses and eventually it'll be better. Obviously, change your IV site. How often should you be assessing your IV sites? Least. How many hours?
4 hours?
I would go 2. I'd absolutely check your IV sites every 2 hours. Yeah. And that's why, I don't know about y'all, but what you've seen in clinical, I always set my IV pumps for 2 hours. Just enough fluid for 2 hours to go into the patient, then it beeps. And hopefully I remember to get in there before the, IV pump starts to beep, but always triggered me to get in there and assess my IV sites. I don't ever put it for a full 8 hours. Like you're just asking yourself for trouble. And I generally worked in peds. So of course with peds, you're assessing your IV site now every hour, every 2 hours. So I just always got in that habit of only setting it for 2 hours. All right. Very, very good. Okay. When you receive a patient after surgery, you've received report over the phone. What is the first thing that you should collect on your patient when they get to your unit?
Vital signs.
Vital signs. I love it. Yes. Common sense stuff. Vital signs. Get your vital signs so that you can start watching trends and make sure that they're staying stable. Okay. Because in report, they're going to give you a set of vital signs. And they should also give you a set of vital signs from before surgery. So start watching your trends. Guys, remember your ABCs, airway, breathing, circulation, okay? And I'm going to say it again when we get to Med-Surg 3 next year. If you just remember, do they have a patent airway? Sit them up first, okay? Are they breathing? Yep, they are. Okay, good, because we've sat them up. Now, what's your circulation? What's their heart rate? What's their blood pressure? What is their fluid and electrolyte status? That's your circulation, and then you move on from there. Okay, very good. What does Schaubach's sign tell us?
If the patient has low calcium.
Very good. What do we give for low calcium?
Calcitonin?
No. That always tripped me up in nursing school. I did the same thing. If they've got low calcium, give them
Calcium.
calcium. Calcium gluconate. Yep. Calcium gluconate. Yeah. But I did the same thing. I always got calcitonin and calcium mixed up. We give calcitonin to reduce calcium levels. Yep. Absolutely. Very good. But Trousseau's and Schaubach's tell us low calcium. Okay. So very, very good. All right. I'm trying to think of any other. Oh, let's talk about asthma. Okay. So I think the big things that you will see on the final are big things that you're going to see in real life. And that's COPD, that's pneumonia, and that's asthma. Okay. And then maybe some flu questions, strep throat, that kind of jazz. So let's talk asthma. What is asthma? Is it an obstructive lung disease or a restrictive lung disease? And actually, I asked that. I think it's restrictive. I actually asked that, and I'm like, do I know? I've always kind of thought of asthma kind of like COPD because it's a chronic thing. I'm gonna look that up. There we go. Yeah, it's obstructive. It's obstructive pulmonary disease. Yeah, I asked that, and then all of a sudden I drew a blank. It is more of an obstructive lung disease. So what does that mean? We're getting a little bit of air in, but we're not doing what's appropriate with it, right? Whereas restrictive is something like atelectasis, where you can't get the air in. I'm saying that now, and I'm getting myself confused. Okay. Where your ability to breathe out quickly is affected by narrowing of the airways. You can get the air in, but you can't get the air out. That's what's going on. Okay. All right, let's not get into the weeds on this. This is not Patho Farm. So here we go. What is a telltale sign that you hear with somebody with asthma?
Wheezing.
Wheezing. What is wheezing?
Inspiratory or expiratory.
Yep, and you can also have an expiratory as well. But what's happening in the bronchial airways? Why are we making that wheezing sound?
Or closing
Getting
a little
constricted?
bit.
Oh, sorry.
Yeah, we're closing up. We're restricting down. And why are we restricting down? We've been exposed to some sort of allergen, environmental, otherwise, that has kicked off our immune system to go into hyperdrive and release all kinds of immune receptors. Kind of like, and I'm getting myself confused because I'm tutoring for MedSurg 3. So MedSurg 3, we talk about ARDS. Acute respiratory distress syndrome, and kind of the same thing happens there. Like your immune system kicks off and it's a nightmare. But with asthma, you get exposed to an allergen, so it basically floods it, things start to swell, your airway tightens up, and you hear that musical wheezing sound. You can have inspiratory wheezing and expiratory wheezing. Obviously, expiratory wheezing, you're trying to get the air out and you just can't. And that's why with COPDers, you'll also hear wheezing as well. You just cannot get the air out. What does it mean when you no longer hear wheezing?
Bad.
Silent chest.
Bad, silent chest. Now they're not getting any air in or air out, and now we're at a big risk, right? So wheezing is an emergency. The big difference between obstructive COPD and asthma is that asthma is like kind of like exacerbations and remissions. So you'll have an asthma attack, but then you go back to normal and hopefully you just continue to bebop on with life, whereas COPD progressively gets worse over time and continuing to smoke and that stuff. I know not everybody that has COPD smokes, but in general, that's the number one way to get COPD and lung disease is smoking. All right, back to asthma. What is the medication we need to give somebody that is having an asthma attack?
Albuterol.
Albuterol, yes, 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 albuterol. That will help open it up. That's our bronchodilator. And then what's our next medication that we give?
Corticosteroid.
Love it, corticosteroids. That tamps down that inflammatory response. And then we're going to give this is more MedSurg 3. We're going to give them racemic epi treatments. We're going to get respiratory therapy. They're going to get continuous albuterol treatments, and we'll go that route. But I think if you know those basic things on asthma, you'll be good for the final. The other thing with asthma is, let's see my notes, if I can see anything. No, I think that's it. So yes, so it's emergency. Wheezing is kind of the telltale sign. It's not the only definite sign, right? And then albuterol is our treatment of choice for that. Okay, very, very good. All right, moving on to, let's see here. No, I'm so over you real quick. All right, let's see, I will try. Sorry. Okay, so let's see here. Pain, we talked about pain. Operative, we talked about atelectasis, OR complications. Oh, what if a patient asks you what their results are from a test? Like I had my, this lab result back. Can you go ahead and tell me my results? What is your response on that?
I'll refer you to your physician.
I love it. Yes. Unfortunately, we can't give test results, right? We're not the doctor. We don't diagnose. Just like everything got chain of command, we got to get the doctor in there. I'll get the doctor in here to talk to you more about it. Very good. Okay. All right. Moving on to a little bit of endocrine as we finish this up tonight. What are the two types of diabetes? Tell me about type 1. How is that defined?
It's more genetic, and it's like basically you don't have the cells in the pancreas, the beta cells, correct? You're not able to create insulin at all, and
right.
So you need continuous insulin administration.
Good. Take out genetic. from your definition, because actually they're showing more correlation with type 2 diabetes being more genetic correlation too. But the rest of it, you 100% are correct. Your body is not producing insulin, so you have to get insulin from an outside source. Very good. When you have somebody with type 1 diabetes and, you see this occur on when they're newly getting diagnosed with it, or maybe they're really sick and they go into diabetic ketoacidosis. What is happening with diabetic ketoacidosis? What's happening with their blood sugar? High or low? Super high. How are they breathing? What's that? Fancy respirations.
Rapid change notes respirations.
Kussmaul's.
Sorry.
There we go, Kussmaul's. That rapid, fast, fruity breath. Remember, that's you're going into metabolic acidosis, right? So that's your respiratory system's way of compensating to try to get you out of that acid-base imbalance. Absolutely. Okay, so rapid, fast breathing, probably a little bit of change in level of consciousness, high blood glucose. What is our treatment?
Insulin drip.
Insulin drip. What kind of insulin? Regular. Very good. Regular is the only kind you can give through an IV. What IV fluid are we administering?
Normal saline.
Normal saline, 0.9% normal saline or sodium chloride. Absolutely. That's the only IV fluid that's compatible with regular insulin. And regular insulin is the only insulin we use in a drip. Okay? That makes sense? All right. So then we're going to slowly get their blood glucose level down to a safe level and then go from there. So that's why diabetic education is so important, especially when they're sick. So you've got a type 1 diabetic. What are some sick day teaching rules? Like they're sick, so do they still need to take their insulin? They're not really eating. Yes, still take your insulin. Okay, when are you calling your provider?
If you have a fever lasting more than like several hours, if you have excessive vomiting, something like that. Sorry.
Yeah, absolutely. What about your in terms of your diabetes? What if they find this in their urine? When should they?
Ketones.
What am I trying to get at? Ketones. Spilling ketones in your urine. Let me see if I can find the specific question. No, I don't have it up. So I'll double check all your sick day insulin or diabetic type 1 rules, but it's continue to take your insulin, check your urine for ketones. If your blood glucose gets above 250, I believe it's call your provider, but I'll double check all that because I know I love to give that as a select all that applies. And I'd imagine she would too. So, okay, good. What is the definition of type 2 diabetes?
Like your pancreas is damaged, or like the insulin that you create, you're basically immune to it and it doesn't work on, in your body.
You're resistant to it.
Mm-hmm.
Yeah, I love it. You're not making enough, or you're become resistant to it. You're insulin resistant. So now we got to put you on some PO meds, usually some metformin, and go that route to try to get you so your body starts recognizing that insulin and so that you can utilize it more effectively. Absolutely. So, okay, what should every diabetic patient assess every day on their body? Eat. Love it. Healthy foot care is important. Daily foot care, healthy foot care is very, very important. All right, good. So things we're going to educate on is our sick day rules, foot care, and then type 2 diabetes. Type 1, unfortunately, you have to have insulin, right? Like that's just how that has to go. But let's say you're newly diagnosed with type 2 diabetes. What are some things that you can do that hopefully may A, make it better, or B, just make your disease process not progress as fast? What are 2 things that we can do? Basic education.
Diet and exercise.
Diet and exercise. That's right. Count those carbs. Get healthier. Can't have donuts every morning for breakfast.
Dang.
And then exercise. That's so important. Exercise is one of those telltale things. Very good. Okay. And then moving on, we'll go one more thing and then we'll stop for the day because I know y'all are smoked. Diabetes insipidus. All right, so switching gears to endocrine. So we've got SAIDH and diabetes insipidus. What are these patients? What is their sodium level? High or low? Diabetes insipidus.
High.
Good. Dry and crispy like a chip. What are they doing? They are excessively peeing a lot. So what are they at risk for? If you're peeing a lot, hypovolemia, dehydration. Very, very good. Yes, they are dry and crispy like a chip. There is something that has gone on neurologically or something that has gone on with the kidneys, like maybe a tumor or something, or a tumor in the brain. We got to figure out if it's neurogenic or nephrogenic that's causing this diabetes insipidus. But long story short, they are peeing. They're becoming super hypernatremic, lots of salt, and they're big time risk for dehydration. Very good. And on that note, let's stop. You all got that right. You all did great on that. So when we meet again later this week, I'll review this again. I'm going to hit more endocrine disorders and just keep quizzing you. But golly, did that help? That seemed like y'all like knew all that stuff. Okay, go have a great night, guys. Thank y'all for coming. I know y'all are smoked. Y'all look great, but I know y'all are probably ready for a nap. So, all right, have a great day. Thank you.
Bye.
Thank you.
Bye.